Thank you, Bill, for that kind introduction. I do realize I'm the last thing between you all and lunch, so we'll make this work. Sorry about that. Let's see. Okay, let's get the talk up here. Let's make a slideshow. And that should be all we need. Okay. So thank you to the TAMEST organizers for the opportunity to be here today. It's really an honor and a privilege to be able to stand before such an august group. My title is Moving Blood, Removing Boundaries, a story of collaboration. I would hazard to guess that in fact, Dr. Gatto and I are probably the only cardiologists in the room. If there is a third cardiologist, if you could meet us after and maybe somebody could explain to me what a zinc finger is, I'd appreciate that. But let's talk about a little bit about oncology, but a lot more about cardiology. So this was from JAMA last week, Journal of the American Medical Association. This was an editorial by Francis Collins. And in that, he was talking about oncology and cardiology and advances we've made. But he really said that, the physicians have approached the treatment of disease in a broad sense for the average patient, because that's really all we had. For the last several years, we've advanced in personalized medicine, and precision medicine is a term you all are very familiar with and have heard about at this meeting. And I think oncology is really the leading group for a precision medicine concept. Cancer death rates, of course, have decreased about 1% per year for the last 15 years. So that all is incredible. But cardiology does well. Cardiology death rates have declined about 70% in the last 50 years, and at least half of that decrease has been in the last 20 years. So two fields that have a lot in common in terms of science in action, improving outcomes and decreasing death. So quickly, my objective here really is just to demonstrate how Houston's medical, academic, engineering, and groups have come together for visualization, for some physical simulation of conditions, some mathematical modeling, all with the goal of improving outcomes for heart valve patients. But really, the subtext here is I just want to tell you a story about learning, about some serendipity, about some flexibility, some progress, and some opportunity with collaborators. And I think every single lecture I've seen here at this meeting, all of the O'Donnell Award winners, which were incredible lectures, the lectures yesterday, the lectures this morning, every one of them has mentioned collaborators. So I'm going to flesh out that story a little bit and talk about how we came to know some of our collaborators and how impactful that's been on the work we've done. So cardio-oncology, that's really not what I'm going to talk about, but I do have one case to show you. So on the left is a normal echocardiogram, 4-chambered view, as we just heard from Dr. Hazel. I mean, imaging, and I'm very thankful to the organizers to put my talk right after his talk, because he's introduced a lot of these concepts. So one of the challenges with imaging the heart is that the darn thing won't stop moving. And that's really a good thing, but it has inherent challenges. Everything moves. So the patient on the left is, the person on the left is not a patient, it's a completely normal study. On the right is a very different case. This is a 30-year-old gentleman who presented to a local physician in San Antonio with flank pain. That led to a CT that demonstrated a completely infarcted kidney. The kidney was dead. A urologist was called. The urologist took out the dead kidney and discovered that the entire renal artery had a clot in it, an embolic clot. They took that clot, the pathologist looked at it, and it was in fact a myxoma. That led to an echocardiogram. How did this piece of tumor get into the renal artery? Well, an echocardiogram was done, and here is a massive left atrial, and in fact left ventricular mitral valve complex atrial myxoma. This is an echocardiogram, again, a slightly different view. What you see is that this thing probably starts down here, we're not sure, but it almost completely obstructs the left ventricular outflow tract. So a massive cardiac tumor. A 3D echo was performed really to try to identify the attachment point. A cardiac MRI, we've just heard about some of the power of cardiac MRI. Here's the tumor sort of attached on the valve, a 3-chamber view, and showing it actually goes and extends past the aortic valve in systole, so a massive tumor. This patient went on to have surgery. This is the tumor sort of being birthed. This is it explanted. It's a mixture of clot, and this is the tissue staining that clearly confirms a myxoma. So this patient actually did very, very well. He had to have a mitral valve replacement. He had a nephrectomy, but has otherwise done well with no really long-term sequelae. But this case I show you to highlight, it's probably one of the coolest cardiac tumor cases I could come up with. The patient did very well and had a very acute presentation, but it really emphasizes some of the concerns with valves, with blood flow, and the interaction, and that's really what I'm going to focus on. So, I've got a bunch of sort of objectives listed here, but really they're just sort of the areas of interest that our research group has been focusing on for several years. To quote Dr. Levine from earlier, I am also going to attempt to transcend some of the technical details. I'll try to keep this fairly aerial in its perspective. But one of the first things that we've tried to do is to explore and really define some of the coupled mechanics of heart valve function. So here is, this should be here. This is a normal mitral valve. This is a 3D echo. We're looking from the top of the heart, sort of down on the valve. You can see the valve, it opens very well, it opens very quickly. Right beside it is the aortic valve. This is a normal valve, does not obstruct blood flow. It stops all blood flow from going backwards. This is a valve with rheumatic mitral stenosis. So this is probably somebody who had rheumatic fever decades earlier, a bunch of calcification, a bunch of fusion of the leaflets. This valve barely opens. This is my favorite video ever to show in a talk because it really doesn't matter whether it plays or not. That's a patient who is exceedingly short of breath. So that's an example of normal and markedly abnormal valve function in some of the imaging that we routinely do now. So the mitral valve complex is shown on this slide. It truly is a complex. It's not just a couple of leaflets that have to open and close. There's a very complicated subvalvular apparatus. We have chordae, primary, secondary, tertiary chordae. We have papillary muscles that attach to the ventricle. All of this needs to be in the right proportion, needs to be in the right place, and it needs to be synchronous in time and do all the right things at the right time. So this little cartoon is just sort of giving an example of some of the complexity of motion within the heart. So this is, the arrows indicate the mitral valve opening, blood flow coming down to the apex of the heart, turning and going back. So the valve has to open quickly and get out of the way. The papillary muscles need to be in the right place so the chordae are lined up underneath the valve. The convexity or the concavity, depending on your orientation, of this leaflet needs to be correct to create a big, large outflow tract so the blood can efficiently leave the heart. So all of this has to happen in one dimension. And the other dimension, we're looking down on the valve again, similar to the images I've shown you. We've got a posterior leaflet that's attached to the muscle or the annulus of the ventricle. It's got to get out of the way. The anterior leaflet sort of falls into the ventricle, kind of like an upside-down toilet seat. It just gets out of the way. But then when the heart contracts, all of this has to come slamming back together. So that's an example of, and it's a very simplistic example of the complexity of the motion of the leaflets. We routinely talk about valves in isolation. I've given many lectures on the aortic valve. I've given lectures on the mitral valve. All of my colleagues do the same. But in reality, they don't exist. It's these isolated mechanical activities. They really are side by side, and they work in concert. And if you look at this video here, it's just a quick example of how these coupled mechanics, in fact, it's more of a push-pull relationship. When the aortic root fills with blood, it pushes on the anterior mitral leaflet and helps it to close. When the mitral valve closes, it helps the efficiency of the blood that's going out the aortic valve. So even at that one level, without involving the ventricle at all, we've got a complex coupled relationship between these two valves. So this is a sketch from Leonardo da Vinci over 500 years ago. I think it projects reasonably well. He had the privilege to look at stationary hearts. Obviously, he never had the opportunity to look at something that was beating. There was no imaging available. They did not do open heart surgery, but he knew enough to show that here's the papillary muscles, the aortic valve, the mitral valve, and he made the first attempts to try to understand the relationships between these structures. I don't know how the chicken legs got into this image. We'll cut him some slack for the chicken legs, but everything else was incredibly insightful. Here's where we are today with some samples of the imaging that we do have now. This is the sort of coupled mechanics of the aortic and mitral valve that I've shown you. This is a three-dimensional echocardiogram with some commercially available tissue tracking now that can help us understand how the leaflets and the dimensions and the angles between these structures work. And as Dr. Hazel has already shown us, cardiac MRI is incredible. So we have now phase contrast images of blood flow. We can actually track blood as it moves through the heart in a macroscopic way. This is a recent publication showing just that. So now we have the ability using cardiac MRI and phase tracking to see streamlines as they cross the valve and exit the left ventricular outflow tract. And if you watch closely in this little video, you can see these little vortices that appear at the apex of the heart. So really this is the beginning of trying to understand not just how do the leaflets move, how does all the anatomy fit together, how do they interact with each other, and how does all this impact blood flow. So this is sort of a little background of anatomy and current imaging, and then a focus on what we were interested in. So our first objective really was to sort of better recognize and quantify abnormal blood flow. So as cardiology, as we heard already, it's not just the geometry and the anatomy, it's the function, and it's human eyes trying to quantitate what's going on. So when I came to Houston about 10 years ago as a research fellow, this was cutting edge technology. This was a 3D echo, one of the first available, and this is looking at mitral valve regurgitation. So the ventricle is at the top, the atrius at the bottom. This is an image of 3D color, a still shot at one point in systole, and we knew that there was a wealth of data here. We have the physicists can talk to us about the flow convergence, the vena contracta, the narrow portion of the jet, the color. This is color Doppler. Doppler is a velocity map. It looks like a volume, but it's not. We have to convert a velocity phenomenon into a volume. That's sort of what we are trained to do, we tried to do. But that was the technology we had, except the machines could do it, but nobody knew what it really meant. So comes in vitro flow lab, the idea that we need to have an independent reference standard to understand the tool that's just been given to the clinician. So this is Time Life magazine from 50 years ago, highlighting some of the work from Dr. William Akers at Rice. And he was using stethoscopes to listen and try to provide a reference standard for the auditory sounds that various prosthetic valves would make. So one of the first attempts to really quantify valve function in an in vitro setting. So again, 10 years ago when I came to Houston, we decided, well, we need to do some first steps and better understand 3D echo. So this was a very simple flow lab, situation we put together. This is an imaging chamber. Flow would come in, go across a valve construct here and go out. This is an echo probe. These little arrows indicate the various places we could put the probe and try to replicate the sort of the imaging windows we would get on a human. This is just an example of the tiny hole that represented mitral regurgitation. And this is the first version of the flow loop. So this is some fairly simple plumbing. Here's the chamber that has a little mock valve in it. There's a big metallic pump back here. It was a piston pump. It probably existed in an auto garage for decades before. We found it in the back of a Baylor lab. This was clearly picture day, so we had a nice blue cloth on the table for everything to look good. There was nothing dirty. But look at the stuff around this room. We had carts and storage, and we really just had a table. The joke was it was our lab, so we dubbed it the Hemodynamics, the Cardiovascular Hemodynamics Imaging Lab, or CHIL for short, but it wasn't a lab. It was just a table in somebody else's lab. But that was version 1.0. It went fairly well. We started to get some three-dimensional imaging of reasonably good quality across these constructs. We started to look at various parameters that would affect the quality of the flow and the shape of the flow, whether it was a circle or an arc-shaped valve defect, which is actually how we encounter them clinically, recognizing fairly quickly that some of the tools that we were using in 2D echo did not translate into the 3D world, and we could not use those same tools. And that was sort of summarized clinically. And in fact, that concept has made its way into all the clinical guidelines, and we understand now from early work in 3D by us and others that we need to have special tools and special abilities to use these new imaging methods. The next objective we had was to take that a bit further and try to understand and predict some of the fluid and structure interactions. And that occurred because at a small meeting, we had the opportunity to meet a mathematician from the University of Houston, Sonny Kanik. We explained some of our work. And very quickly, she was very interested and said, well, we do computational fluid dynamics. We would love to be able to work with you about validating some of the mathematical algorithms we've created. So with our flow construct, their group very quickly created a mesh defined in a computer world, a software environment, the same geometry. We provided the input in terms of the flow. They very quickly were able to create constructs or mathematical constructs of what the flow should do based on assumptions of the flow characteristics, but with known geometry that we provided. And we got to compare computational flow dynamics with 3D color Doppler. And this is an example of flow moving from left to right across a mitral valve. This is the schematic of what we thought was happening. This is a 3D echo of what we saw happening. And then we compare, well, here are streamlines, the orifice, the vena contracta, and really helping us as clinicians understand the tools that we had and helping them as mathematicians understand the limitations, accuracy of their computational models. So quickly they were able to compare the computed velocities against our Doppler measured velocities. The correlation was excellent. one of our first publications looking at 2D Doppler, 3D Doppler, and computational flow dynamics to define flow in 3D across a mitral valve. Quickly, we decided that we had some needs. We wanted to get past this. We wanted to improve our heartbeat simulation. And we also ultimately wanted to make our flow loop MRI compatible. As we've heard, ferromagnetic parts and MRIs don't necessarily go very well together. So we were seeking flow control. I showed you the pump we had. It was a fairly simple piston pump, very difficult to program to do anything other than push-pull at its own will. But we had, this is a screenshot from some of the early oscilloscope we had. There were various spikes and things that we didn't want to see, but we kept seeing. We ended up achieving flows that looked like mitral valve regurgitation. But we really knew we wanted to see things that looked like this. We wanted to control the systolic period, the ejection period. We wanted to be able to have a more sophisticated pump that could create the things we wanted. So that got us to the next version of our flow system. We've exchanged our pump for a left ventricular assist device. We have a little more control. This is an image of the lab. We've expanded. We have more than just a table now. We still have the same table, but a little more space around the table. So slowly we're growing in stature at our institution. But this gets to, we had needs. We knew we wanted to expand. Here comes industry to the rescue. So a sideline, Pumps and Pipes is a program that has just had its 8th consecutive annual meeting. That was in December. You see the sponsors there, ExxonMobil, University of Houston, NASA, Houston Methodist. It's grown enormously. It's the concept of you get petroleum engineers, clinicians, physicians, engineers all together. And you realize we're all about flow assurance, we're all about remote monitoring, we're all about new materials and how to develop them and use them. It is the proverbial, let's explore the other guy's toolbox scenario. And it's grown and it's a subject of its own lecture and many other lectures. Some of the hype of the coverage that the recent one got was really just incredible. Multiple national simulcasts, but a very impressive meeting. But at the first one of these, or shortly after the first one of these 8 years ago, we had the privilege of a tour. A tour came through our lab, and on that tour were some ExxonMobil engineers. And at that time, we had already spec'd out a new pump. We had this axial linear actuator, which is a fancy pump. It's kind of like a big screwdriver. You tell the computer what to do, and it goes back and forth, and it gives us all the control we needed. So we sort of did the specs. We knew we had the right pump. But this pump kind of came to us like as if you bought a car from IKEA. It was just in a box with an Allen key. And we didn't know how to put it together. We didn't know how to organize it and make it work. And we spent several months trying to come up with programs and trying to identify people who could program it to do what we needed it to do. Lo and behold, an ExxonMobil engineer, Tom Lindsay, is on the tour, sees the pump, says, hey, I've got that pump. I've got the same pump. Mine's bigger. But how do you run it? I said, we don't know how to run it. We need you to help us run it. So this is an example of what they were doing. So the ExxonMobil facility, the upstream research facility, they have these enormous facilities, and this is an example. This is the end of their piston. It's behind a big wall of plexiglass and safety. It can create 3 million pounds force, and they use it to crush rock. To put that sort of number in context, when the shuttle takes off, it's about 7 million pounds thrust. So this is an enormous amount of energy. This is the actual actuator here. This is the piston that it controls. This is the result when the piston does something. It, in very controlled fashion, crushes the rock. So within about a month from the meeting, the fairly lucky meeting of seeing our pump sitting on the counter, they had produced for us a little cart. And on this cart was our pump with an entire control system, the software, the controller, the switch, the actuators, everything delivered to us. A van pulls up the loading dock of the hospital, and here's something that can keep us going. Well, on the front side of that laptop was a heartbeat simulator, a software that we can't do without now. This is really an on-off switch, and the ability to control and really replicate any patient's cardiac cycle that we want to, a long way from the linear pump we began with. We demonstrated multiple times that we can control the heartbeats. So I mentioned the other needs assessment we have was to get in the MR scanner. We had, this was a version of our loop full of metal things. We could easily get rid of the metal things and replace them with non-ferromagnetic components. But unlike a human being, there wasn't an actual heart. We needed to pump the flow. So pumping the flow was a challenge. You've heard this already. This is magneto. So the thing I learned is that the MRI magnet is always on. And if something gets too close to the magnet, it's embarrassing to try to get it off the magnet. So somebody had wheeled the chair a little too close, and then there's 3 guys, 2x4s, ropes and pulleys. Eventually they were successful in extricating this from the magnet. It's not always the case. Sometimes you cannot get it off the magnet. It costs about $80,000 to turn off the magnet. So the institution frowns upon that. So we go to great lengths to not ever turn off the magnet. Bill Klein has already shown you one of our interesting patients. So this was a gravel pack simulator. So the gravel was replaced by these plastic beads created at Exxon. This was part of the great relationship. They were giving us the tools we needed, but they had a question. They said, we would like to look at the flow within a gravel pack bed. We put this gravel pack bed, you saw the slide already. What you didn't see was the output. So the gravel pack experiment was really very interesting. They saw for the first time using 4D MRI the flow within the gravel pack. And here you actually see the streamlines. So they had a very unique insight into the way that their gravel packs were working, and they made a fundamental design change to improve it. So that was their benefit, and that was clear. Our benefit was like, wow, they just put a gravel pack into our MR scanner. How did they run this thing? There was a really, really big metal pump in the back of the room. It was about the size of a fire hydrant. And from that, we realized we just need distance. We don't have to be that afraid of the magnet. We just have to adjust to the magnet. And found in the discussion, we discovered there's a 5 Gauss line, and as long as you're outside of that distance, 10 feet or so, you can have metal in the room. So then we did a redesign. That's the schematic, and that was the product. So this is our heartbeat simulator, a long aluminum, non-ferromagnetic construct, a very long piston. We have to be on the left of this line, not the right. The right, you saw what happens. And our heartbeat simulator is now inside the magnet. With that, we were able to carry on and do a whole series of experiments and recent publications looking at prosthetic valve flow, because now we can create pulsatile, controlled, reproducible flow within an MRI magnet system. Next objective we had was really to combine some of this computational and physical models to simulate more complex multi-physics problems. So I've talked to you about modeling. Why do we do any modeling at all? Well, bench design of interventions, be them valves, prosthetic valves, left ventricular assist devices, catheters, anything, even drug design. At first, there's an element of fatigue testing. You go to animal studies for feasibility. There's cost and ethical concerns, and then, of course, relevance with animal models. You go to human studies initially for safety. There are ethical, cost, and regulatory concerns there, as we've heard about, and then finally, human studies for more efficacy with cost and regulatory limits. And then if you make a change, you often have to start over again. Well, anatomic models that are coupled to physiologic flow conditions really give you a controlled and reproducible testing environment, and it's a very cheap arena for mistakes and innovation. So historically, what's happened is 3D printing has come along, rapid prototyping. We've changed our models now. We actually print, instead of sending a piece of plastic to a machinist, we now print out chambers that have roughly human ventricular geometry within the inside. There's an example of a mitral annulus, which we know from 3D imaging studies is actually saddle-shaped and dynamic. This is a pig valve affixed within our loop. And what we began to model then were more complicated versions of mitral valve function. This is a video of a normal valve from one perspective. This is the long axis view. You can see the chordae flexing and the papillary muscles working. All we did was simply reposition one of the papillary muscles, making the chordae now relatively too long. And hopefully you should see it here. This area here is prolapsing. This piece of leaflet here where the arrow is bulging back into the left atrium. So what we're doing is replicating the human condition of mitral valve prolapse. And these are long axis views. And this is the other main problem we have, is a different type of mitral regurgitation called functional mitral regurgitation. This is the condition where the left ventricle suffers a myocardial infarction or a heart attack. The chordae are now relatively too short and the leaflets are pulled apart. So In the in vitro situation, we were able to create these constructs. And then this was all done in collaboration with folks at Rice Bioengineering, and Jane Grande Allen, who's with us today, was pivotal in some of this development. I'll just move over. There we go, sorry. All right, so this ability to create the models, these models were co-developed along with Rice. We would create the models and the ability to hold the mitral valve to do the functional imaging. But in Dr. Grande Allen's lab, they would actually take the models, grow them in a bioreactor, which is a sterile nutrient media with the same or similar flow conditions. And this is some work that we recently completed and is being submitted. And we demonstrated that really very quickly, within 1 week of tissue growth in a bioreactor under the hemodynamic conditions that are similar to mitral valve regurgitation, we see that there's a cellular remodeling of the leaflets. So these leaflets aren't dead tissue that just open and close and move out of the way. They're very active. And in fact, by creating mitral valve regurgitation in vitro, we see that the leaflets, in fact, start to behave and look like the leaflets we see. So there is myxomatous type changes within the leaflets. The increased levels of collagen 3, increased glycosaminoglycans, concentrations, they become thicker, they become more hydrated. So in one extreme, we have created these valves that very quickly look like myxomatous mitral valve prolapse. And we've got some other preliminary work showing that if we do the opposite and we make the cords tensioned with regurgitation, they actually start to behave like functional mitral regurgitation. They look like functional mitral regurgitation valves. So sort of demonstrating, and it's our first foray into mechanobiology, and we're learning an enormous amount from this collaboration with Dr. Grande Allen, that in fact these leaflets aren't static structures that open and close. They're very reactive to the hydrodynamic effects that they're under. Another important collaboration for us, again, with the University of Houston, and this is an NSF collaborative effort, advancing the diagnosis and quantification of mitral valve regurgitation. Again, what we're looking here is when the mitral valve jet hugs the wall, instead of going straight up the middle into the left atrium, it hugs the wall. So now you've got frictional forces acting on this abnormal event. As I mentioned earlier with Doppler, and really most of our techniques, we try to equate velocity as volume. But when there's frictional forces slowing down the velocity, it changes all of the quantitation that we're able to do. So this is an example of a clinical case. So this is a patient with a very wall-hugging jet of mitral regurgitation. We created a similar thing in vitro. And Dr. Kanik and her group create the mathematical equations that help solve this. Now, maybe like many folks, I went into biology and ultimately medicine because my mathematics was not as good as the engineers and mathematicians. So when I see the formulas that Dr. Kanik and her group create here, I recognize the plus and the minus and the equal sign, and literally everything else is Greek. But that's okay, because she understands it in her group very, very well. And what they do is then create these computational models, wall-hugging models, and they're really working to help us understand the fudge factors that we use clinically. We just downregulate a bit. We don't know whether it should be 5%, 10%, 20%, 50% in terms of our quantitation of these problems. And this is a little video they recently created showing the flow come in and go across this mitral valve construct. And this is a clinical case showing the wall-hugging jets. So this, for us, is a very exciting collaboration. It's going to have, we believe, a direct impact on some of the quantitative tools that we use clinically and quickly. A lot of unexpected dividends. This collaboration, or these two collaborations I've just mentioned, led to invitations to a math bioengineering meeting at Ohio State that went on for 3 days, and it was a collection of mathematicians, engineers, clinicians, and surgeons, and we talked about heart valve design. We were asked to create a summary paper of this meeting. It was so big, it's now been broken into 4 parts, 3 of which have already been published. So some interesting, unexpected dividends from that effort. The final objective I wanted to talk to you about was just repair and restoration of cardiac function. It's a lofty goal, but it's one we keep in mind at all times when we're doing our work. This is an example of aortic stenosis, a normal valve here at the top, a severely calcified degenerative valve that might be typical of an 80-year-old. Technology that's currently available, if you've not ever seen this, I'll just walk you through this quickly. Transcatheter aortic valve replacement. So for select individuals, we no longer open the chest to change the valve. We can implant valves going through the leg artery. So that was a little video, a little animation of a calcified valve. And here's how we approach this. And we are one of the larger programs in the country doing this technology. So a wire is implanted up the femoral artery all the way to the beating heart. We cross the heart. The wire now sits in the left ventricle. You follow it with a special catheter. On the end of that catheter is a balloon. The deflated balloon goes across the valve. The heart is made to stand still effectively by pacing it at about 200 beats per minute. And during that standstill, the balloon is inflated. So what we've done is we've sort of crushed the valve, moved it out of the way. We've opened up the squeaky door that wasn't opening properly. This is a larger catheter going in, and now a catheter with a compressed, stented valve on its tip. So the valve crosses the aortic arch, a little rotation and spin. It gets positioned over the mid portion of the native aortic valve, and then the balloon is again inflated. So this is a balloon-inflated prosthetic valve. So the old valve is just crushed out of the way. The new valve now sits inside of it. And the video will continue. We'll look down on the top of this in just a moment. It's a little analogous to putting a new door inside of an old door frame. So this, this used to be a very large sternal surgery, heart-lung bypass, 7 days in hospital. Now, for the right patient, we just do a poke in the leg. You put this in, there's no scar, and that's the therapy. And this has sort of revolutionized what we're doing in the valve world. That video is about 5 years old. There are other technologies for mitral valves and other interventions, so that's sort of transforming what we do. But these aren't surgical valves. They don't have the touch of a surgeon sewing them in. The Achilles heel at the moment is a little bit of leak around the outside. So we can get these effects of paravalvular leak, and that's the problem with the technology. So we're working to improve upon that. Rapid prototyping. Many of the engineers here will be familiar with. It's making complex three-dimensional structures using a myriad of different materials. Mostly they're made from plastics or resins, but in fact you can use bronze, ceramics, stainless steel, silver, and gold. And indeed, you don't need one material. You can fuse different materials using a 3D printer and create really anything your imagination designs. So this is 3D printed, these are CAT scans from 4 different patients of ours. They all have a different left ventricular geometry. They all have a different geometry of their ascending aorta. What we've done recently is created dual material fused models of specific patients' aortic valves. We take a CAT scan. It clearly identifies calcium and non-calcified materials. We export that digital data set, and we make computer-assisted drawings of stereolithographic files, and that gets sent to a 3D printer. And the 3D printer, by fusing the calcium and non-calcium sections, creates for us physical models that represent our patients. And this is viewed, these are 5 different patients printed. This is the long axis view of their aortic valve. This is the view from the aorta looking down on the valve. This is the view from the ventricle looking up on the valve. Every one of them has a different shaped geometry. Every one of them has a different sized orifice. Again, we turned to our colleagues at Rice and said, well, are these structures that we're printing, do they have any sort of relationship to the material properties of a human aorta? They performed for us some calcific compression testing, as well as some tensile testing. And indeed, it's very difficult to find what normal should be for an 80-year-old explanted aorta. But within reason, the material properties are very representative. So we didn't just want to make these models to hold and look at. We wanted them to function like aortic stenosis. So this is one of our patients. We put that model into the flow loop that I've been showing you. And you can see it pulsating. This is the patient's echocardiogram on the left. This is patient number 18. I had a model done here. This is the model we created. This was the echocardiogram that quantified the aortic valve stenosis as well as the leak. We would measure the velocities and the gradients across the valve. Then we subjected the model that we just printed to the same type of echocardiogram and discovered that, in fact, we replicated very closely the functional characteristics of this structure, not just the look of it. Because we had created an MRI-compatible flow loop, we couldn't resist. We had to put one of these aortas into our flow model and do an MRI, and that's shown here. And then using, again, what we've heard about is some of the 4D capabilities of MRI and flow measuring. You can actually see that this is the aortic valve construct for one of our patients. 4D MRI is difficult to do clinically in patients. It's particularly an older patient. They have to lie still for a very long time, so it's not quite ready for prime time application in a clinical sense. But from a research perspective, to understand what's going on at a certain level, it really is hard to beat. And you can see that both path lines and particle tracking, as well as streamlines. And if you compare that to, again, one of Da Vinci's drawings from 500 years ago, he had a sense that the structure he was looking at should be creating these little eddies and vortices in the aortic root that would help to close the valve and give flow down the coronary arteries. Well, that's exactly what we're seeing now in cardiac MRI structures. We also wanted to do the very interventions that I showed you in that animation. So we took one of these transcatheter valves and we implanted it into the patient. So we took the same size valve that the patient ultimately received and we replicated their interventional procedure on a tabletop. And this was the patient's echocardiogram after the procedure. They had a leak here and here. So that patient's specific anatomy and calcium made an imperfect seal when we deployed that valve. And in fact, when we deployed the valve in the model, we got the exact same leak, shown here and shown here. So in fact, we've demonstrated that you can create these patient-specific functional models and that these models have some potential to help us understand how to better provide the therapy. So final couple of slides. We have a lot of conversations with patients about estimating risk. And the conversation often goes something like this. Doctor would say, Mrs. Smith, during aortic valve surgery, the risk of death is 4 per 100 cases. We try not to say percent. We keep it real simple, 4 per 100 cases. And often the patient will reply with, what number are you up to? I kid you not, that happens often. Where we hope to go is have a conversation that's a little more like this and say, based on your specific anatomy, we are going to alter our implant procedure and our device choice to reduce your complication risk to less than 1 in 100. They're probably still going to ask what number we're up to, but we're going to change the tone of the conversation a little bit. So you've heard already about toolboxes. There are many toolboxes in the nation, in the States, and even around Houston. These are some of the toolboxes that we've been lucky enough to rifle through to find not only the tools, but the people that could really move our work forward. And I encourage all of you to ask the question, sort of what's in their toolbox. The summary message that sort of I've learned from all of this is that cardiovascular innovation is happening. I think mostly it's happening, or the part I'm most impressed with is the sort of intersection of imaging and intervention. And that's at multiple different scales. I work in the macro world with big, palpable valves. Some folks work in coronaries, which are in the order of 5 millimeters, but we have colleagues working on the nano scale. So I think interventions and imaging are intimately connected, and that's a large part of where the most interesting innovations will occur. But in terms of the collaboration, we've learned a lot as well. When we started with a peanut butter jar and a balloon, and I don't think we didn't realize how much we didn't know. When we talked to our colleagues and collaborators, ultimately, we didn't realize how much they didn't know, not about their fields, but about our fields. And it's quite amazing when you interact with smart people. It's really easy to educate them. And it's incredible to watch our bioengineer talk to a bioengineer from ExxonMobil or from Rice or from University of Houston, and how quickly they understand each other. That still amazes me. So really the solution to your problem may already exist in someone else's toolbox, and certainly the specialties you need may be there as well. So this is our team. It's a large team from Methodist, Rice, UH, and ExxonMobil, and that's my final slide. Thank you very much. Any questions?
I'll just make the comment that that was an excellent closing lecture for this conference because of the collaborative efforts that you have certainly employed in your work and represents this group very well. Thank you very much.
Terrific. Thank you very much. Dr. Gatto.
Yeah, enjoyed your talk very much, Steve, and congratulate you and Dr. Lumsden and your colleagues on this collaboration between industry and academia. I think this is an excellent example of the type of interaction that TAMEST wants to promote. I had one question. Are you able to model with a left ventricular assist device continuous versus pulsatile flow, and what are your conclusions about it?
We haven't done it yet, so I don't have conclusions, but I'm optimistic that we can. One of the attractions of that model is that a heart that is so bad that it needs a left ventricular device has very little motion. So it's easy for us to create three-dimensional printing of something that's not moving very well. So we've talked to our heart failure group about that, and that is something we want to pursue. I think it would be very interesting. I mean, there's lots of areas of interest in terms of the pulsatile, non-pulsatile, the interaction of the mitral valve, the aortic valve. So I would say let's keep talking about it. That's an area we want to get into, but we haven't done it yet. Okay, well, thank you very much, everybody.